A very good afternoon to one and all. I am Arpita, the moderator for today's session. The topic that we have chosen today is emergent management of ectopic pregnancy. Now, to describe about the topic, the emergent management of ectopic pregnancy is critical due to the potential for life-threatening complications such as rupture and severe hemorrhage. An ectopic pregnancy occurs when a fertilized egg implants outside the uterus, commonly in the fallopian tube, but can also occur in the locations like the ovary, abdomen, or cervix. So, to address this very critical topic, we have with us Dr. Narmada Hadigal ma'am. Ma'am as MBBS, DGO, DNB, DPHA, MNMS. She's a former professor of obstetrics and gynecology at the Osmania and Gandhi Hospital. She is a fertility specialist at Narmada Women Health Center from Hyderabad. So, ma'am, with this very brief introduction of yours, I would request you to please start with the topic for today. Over to you, ma'am.
Thank you. Good morning, everyone. Today, the critical topic is ectopic pregnancy management in emergency situations. And the topic is, here in India, the maternal mortality of the ectopic pregnancy little bit has come down due to new techniques in surgeries and also diagnosing early because with the help of the ultrasonography and also doing laparoscopy, minimally invasive surgeries and other things. The incidence of ectopic pregnancy, and of course in India, is lesser than in other countries because we have less pelvic inflammatory disease compared to other Western countries. But in India also, the incidence of ectopic pregnancy varies from the 1 in 250 to 1 in 100 pregnancies. And moreover, the main important thing in ectopic pregnancy is the maternal mortality due to uncontrolled hemorrhage. But that nowadays it has come down a lot. And it was one of the major maternal mortality in foreign countries till now. So, coming to the problem, and pelvic inflammatory disease, that is a PID, is the most important etiology for the ectopic pregnancy. After that, and other thing is intrauterine contraceptive devices, where we use to prevent pregnancy, and also progesterone used pills. And progesterone, I'm like progesterone medicated IUCDs also cause little bit of movement in the tubes, and slow movement may also cause this implantation. So usually pregnancy will be always intrauterine. If there is outside the intrauterine pregnancy, it is uterine and also extrauterine pregnancy. Coming to the uterine pregnancy, the most common site is the tubal pregnancy. Next one is the interstitial and also cervical pregnancy, and also some abnormal corneal pregnancy is also there. As we know all, there are four portions of that four parts in the tube, like interstitial. Ampullary region is the most important and more commonly the ectopic pregnancy can occur in the ampullary region because it is little bit wider and crypta formation are more. And as we all know, the fertilization will occur in the fallopian tube itself, but it will take, once fertilization occurs, it will take 2 to 3 days to come into the actual uterine cavity. But during this time, if there is any problem in the way to this blastocyst and fertilized ovum, and the ectopic pregnancy can occur. So here the pathology, the main thing is pathophysiology is the cilia. As we all know, and ectopic, this tube has musculature wall, and above that peritoneal wall, and inside the musculature there are cilia. Cilia will be there. Cilia will be there, and these cilia are there on the columnar epithelium. When there is any infection is there in the tube or outside the tube, that will enter into the they enter into the fallopian tube, their crypta formation will occur and balding of those cilia will occur, and also the LA, like a small LA and portions will form, and there the egg may that fertilized trophoblast may implant. So the defect in the cilia can occur, and also the epithelium and also musculature, because of all these, because of the infection in the fallopian tube. So, and not only this, and in tuberculosis patient, the tuberculosis patient, the problem is may be very severe, and sometimes the balding of the tubes can cilia can occur, and cilia will not be present, and also epithelium may be infected, and there won't be any epithelium to propel the this fertilized blast, and and also not only that, and blocked tubes will be there, and not and coming to another problem, congenital malformations, congenital defects in the tubes, like like there can be accessory ostia, diverticulosis will be there, stenosis of the tube will be there, and polyps may be there, and hypoplasia of the tube may be also there. In all these congenital anomalies, and the fertilized egg may not travel properly into the uterine cavity, and also adenomyosis of the uterus. So we are talking about everything about the tube. The problem is in the tube. So adenomyosis of the uterus, in severe endometriosis also, the motion and movement of the tube may not be proper. And also in fundal fibroma on the uterus, and that also the movement may not be properly, and the restricted movements will be there. One more thing is, important thing is previous surgeries on the tube itself, like like a ventral suspension from the some with a round ligament, and also tubectomy, and recondylation of the tube, and reconstructive surgeries in the pelvis. All these will cause may cause ectopic pregnancies. And even laparoscopic tubectomy, small ostia on the distal side may get opened, and ectopic pregnancy can occur. And also, next one, nowadays we are doing IVFs, because of the number of the, we are inducing the patient for the more eggs, and there also we get and more chances of getting ectopic pregnancy. And also how much quantity of, during embryo transfer, how much quantity of the media that we are putting in the uterine cavity, and how many eggs and how many embryos we are inserting into the uterine cavity counts a lot. All these things, and also previous history of the adnexa. Also, we have to think about the adnexa, like appendicitis. Whenever patient had appendicitis in a previous previous this thing, and they have local infection, like ruptured appendix or normal appendix surgery also, adhesions may form in the abdominal cavity, and also in the right iliac fossa adhesions may form, and also sometimes pus formation can also, appendicular abscess, and those things also, these tubes will be affected, because tubes are very delicate structures, and with all these cilia and other things, the construction of these tubes are very delicate. And in older women, coming to the older women, and defective embryogenesis itself cause may one of the causes for the ectopic pregnancy. So the recurrence of the ectopic pregnancy is also very high. So here we have discussed not only that, the pelvic and abdominal surgery, smoking, douching, and multiple partners whenever they have multiple partners in sexual partners, and they have more chances of having pelvic inflammatory diseases. And if patient had previous ectopic pregnancy also, once if she had a previous ectopic pregnancy, there are chances, about 12.8% chances again she may get ectopic pregnancy. If she had 2 times ectopic pregnancy, she may have 30% of chances for this third ectopic pregnancy, like that. And if three times if she had 75%, like it goes on, the instance will goes on like that. So and when we do laparoscopy for normal infertility patient, and always if patient is having infertility, and also when we diagnosed on the table itself that patient is suffering with the pelvic inflammatory disease, there are chances of 7% of ectopic pregnancy will be there when if you diagnose on the table itself, like that. And also when people undergo MTPs, like previous history of in one or two MTPs, and genital tuberculosis, all these things happen because of the damage to the epithelium, and also desquamation of the epithelium. The slow desquamation will occur, and also adjacent plicae to the tubes will get spoiled, and it will adhere, and blind alleys will form, like blind places will form. There the egg may get implanted and very dangerous for the patient. We all other things we have discussed. Uh, Coming to this contraception, progesterone contraceptive pills, what will happen when you use only progesterone contraceptive pills? The progesterone contraception will act only in the 95% will act in the uterus, and also distal part of the tube, and proximal part of the tube, and distal on the distal one third of the tube it will not act. That progesterone and that slow movement will not act. So there also especially in the IUCDs, and the distal part may not act on the thing, and ectopic pregnancy chances are more in those people who use this contraceptive progesterone contraceptive devices, and also this progesterone contraceptions. And sometimes people they undergo tubal pregnancy, most of the times when they undergo tuboplasty, only 40% of success will be there. If they do even plastic surgery also for the recondylition, those things, only 40% chances of the normal tube will be there. Rest of the patient, they may have ectopic pregnancy most of the times. That is the reason, even if you use microscope and do plastic surgery, the chances of the ectopic pregnancy will be there. So the classic triad of the symptoms, in ectopic pregnancy, is most of the times patient will come with the pain abdomen, and also pain abdomen, and the instance of the pain is very almost 90 to 95% of patients they come with only pain abdomen. Whenever patient is married and she is having pain abdomen and little bit of bleeding and missing period, like amenorrhea for 1 or 2 weeks, or even for 4 days, always we should think about the ectopic pregnancy. So this and this is the classical triad of the symptoms: pain, amenorrhea, and little vaginal bleeding. Some people may have severe bleeding also. So abdominal pain is the most frequent and common symptom with the patient will come. And also because of the hemorrhage in the abdomen, once what will happen, once that sac ruptures, that will antimesenteric border will be there, and peritoneal border will be there. If it ruptures and it will pierce that musculature, and if it comes out of that peritoneum, it will go into the abdomen. Otherwise, if it is coming into the antimesenteric border, it will go into the broad ligament. There also broad ligament formation can occur because of the bleeding. Because broad ligament has lot of dead space. There the bleeding can occur, and also hematocele will form, and patient will have lot of pain. And in those retroperitoneal hematoma will form, and patient will have more pain. And whereas if it is goes into the abdominal cavity, there they will present with the shoulder pain, back pain, and because of the irritation under the diaphragm with the phrenic nerve, and they will have lot of pain at the shoulder, and other things can occur because of the intra-abdominal hemorrhage. These things are very, very common. They present like that. And coming to this amenorrhea, and always we should clinically we should ask how many previously, whether she used to have normal period and how many days cycle. Sometimes they say already I had a period last week only, but still I am having bleeding like that. They present like that. So that is almost a vague complaint, but pain and vaginal bleeding, of course, anemia, this amenorrhea, all these things are very, very important. This is the thing. And coming to the history, we always try to take more history. We should always think that what she's saying, and what is whether she is in good condition to say, or otherwise we should ask our her relatives or attendants like that. And whatever the bleeding that she is having, and the cast, some residual cast, they may pass. And that also, if it is possible, we should see it is smooth in the uterine side, and rough on the other side. So and this is the important sign that if she passes the that residual cast, and in almost 10% of cases women will pass like that. Sometimes in we may just think that maybe she's having threatened abortion or some other abortion, whatever it is. So we have to try to elicit what are the exact signs and symptoms she has. And by taking the history, most of the times we can diagnose this ectopic pregnancy. But most missing diagnosis of the ectopic pregnancy is being and unless until a patient will come with the patient comes with this all these symptoms, we miss. Otherwise, sometimes patient herself say, she may say that I am having severe pain, maybe ectopic pregnancy, because nowadays they know what is what like that. Coming to the physical examination, immediately when you see the patient, if patient ruptured ectopic pregnancy, definitely you can guess that she came with the ruptured ectopic pregnancy, because patient will look paler, and her skin will be cold and clammy, pulse rate will be more than 100, and also blood pressure may or may not be normal. Maybe sometimes if the bleeding is severe in the intrauterine cavity, she may have low BP also. And of course, tachycardia will be there, severe tachycardia will be there, and hypotension. And if severe bleeding is there, even air hunger, like she may have little bit of dyspnea and other things. She may not sit properly. She may not lie in one position. She has to search for the good position to make herself comfortable. And coming to the proper examination, whenever patient comes to us, always better to do examination, and general examination has to be done, and abdominal palpation of the abdomen, and it is whether rigidity is there, tenderness is there. Of course, tenderness will be there in all type of cases, but rigidity may or may not be there in all cases. And always better don't hurry to do pelvic examination if pelvic hematocele is there in her pelvis, and she it may get ruptured, and the condition of the patient will become more worse. That is the reason always when you suspect a patient in shock, I mean hemorrhagic shock, better to take her into the uterus and start doing examination. So when you start doing under aseptic precautions, when you start doing examination, she may her bleeding may be there. Most of the times, the bleeding will be dark in color, and also small clots and pieces of endometrium you can see. And cervical motions may be tender cervical motions may or may not be present, and sometimes bulging of the cul-de-sac, bulging in the posterior fornix, we see that in the cul-de-sac, and that may be also very much tender. And also, or maybe on the right fornix or left fornix, because if big broad ligament hematoma is there, you may see. While doing that, we should do always gentle two-finger examination, and otherwise, if you do in a hurry, and it may get ruptured and patient may go into shock. So under good full setup in the OT, we should do all these things. So adnexal mass may or may not be palpable. Most of the times, it is only in 25 to 50% of cases it is palpable. And another diagnosis, but of course, nowadays we do ultrasonography immediately whenever the patient comes. But to confirm that also, and we can do caldosynthesis. We can put 16 to 18 gauge needle in the posterior fornix and lift the cervix, posterior lip of the cervix, and under aseptic precautions, put needle slowly and try to aspirate. That is called caldosynthesis, and see whether how. mm, what is the color of the blood, whether the blood is freely coming or not. And if fresh blood is there, we are going into some wrong space, something like that. So the blood always is non-clotable blood. Most of the times it is non-clotable blood. Like this, we can, if the picture has given, and you can see the picture like that, injection. So, so always when patient coming in emergency like that, all the, I mean, team should be there, because this is one person cannot manage these kind of patients. The team should be there, and there the in team, and one has to take laboratory tests, like one has to check her blood vitals, and other has to be other doctor or nurse, anybody to order for the blood, because blood we have to reserve blood, or you have to get immediately blood based on our hemogram. Like first thing, we have to do blood grouping and typing, and also hemoglobin levels, and other normal tests like serology and CBP, creatinine, urea, and other things compulsory we have to do. Main thing is hemoglobin and blood grouping. And if patient is, because why we do RH typing means, if patient is more than 6 weeks or 4 weeks of, more than 6 weeks of pregnancy, even in RH negative, we have to give anti-D, like immunoglobulin, we have to give. So, so coming to the diagnosis, and this hormonal diagnosis, serum beta HCGs we do. And when patient misses her period, and we can see in urine pregnancy test if it is positive or not. But the main thing, when patient become ovulation has occurred and fertilization has occurred, within 9 days, serum beta HCGs will start increasing. And every alternate day, if you do, it should get doubled. And but whereas this urine pregnancy test will show only after 15 days of our post-ovulation positive. Like HCGs almost serum beta HCGs will be positive, and it is very good. In 99% of ectopic pregnancies, serum beta HCG or and gravidex test will be positive. And in some cases, it may not be positive. And preferably in chronic ectopic pregnancies, it may not be positive. So this one of the tests is serum beta HCG is very, very important. And always we should see if you have unruptured pregnancy, we always we can do serum beta HCG and alternate days. If you suspect ectopic pregnancy, and if it is not doubling, like, or else it is, if it is decreasing, then you can think of the even ectopic pregnancy. So, see, coming to this, even serum progesterone levels also, this hormone test also we can do. And if it is below 5 nanograms per ml, and almost maybe dead fetus or ectopic pregnancy. If it is more than 25, you can think of you can exclude the ectopic pregnancy. And also the main gold standard, almost gold standard is the only laparoscopy, but ultrasound is do. But in transabdominal scan, we may not visualize the sac properly. But in vaginal scan, and if it is small also, sometimes we can recognize that there is uh, sac and ectopic pregnancy is there. And also, first thing we have to exclude what are the things that you are supposed to see when you do pelvic scan, that is transvaginal scan, and see if the empty uterus is there. That means there is no sac in the uterine cavity, and trilaminar endometrium may or may not be there, and see outside. And if there is some fluid in the pouch of the Douglas, always think about the ectopic pregnancy. And you may or may not see the sac at that time. If you see, and if it is more than 2 centimeters, 1 centimeter, sometimes you can suspect. But most of the times, you may see that dominant follicle and other. So this is the imaging of choice in early pregnancy, and almost only 20 to 50% of cases we can detect that we can diagnose whether she is having ectopic pregnancy by even by transabdominal scan. So then what we should do? If we diagnosed ectopic pregnancy, patient is cold and clammy, and how to manage this patient immediately? We have to do the gold standard is laparoscopy, that is minimal invasive surgery. And if it is not available in some hospitals or in rural areas, but better to do laparotomy. But if it is negative, and always we say that if it is negative finding also, better to rule out whether ectopic pregnancy is there by putting one scope in the abdomen. So this is the definitive, not only diagnostic, and this is the definitive operative therapy. So that is the gold standard for all ectopic suspected or ectopic pregnancies. And coming to this tubal pregnancy, we thought of thinking about all these types of pregnancies. In tubal pregnancies, what we should do? In interstitial pregnancy, what we should do? Like this, all these pregnancy, what kind of things we should look in the abdominal cavity. Suppose if it is tubal pregnancy already ruptured and hemoperitoneum is there, suppose somewhere it is in ampullary region, bleeding is more, then you have to do do the suction all over the abdominal cavity. And when we put the scope inside the abdominal cavity, we need not to become very much panic, because everywhere the blood red color is seen because of the hemoperitoneum. Immediately mm, we should do aspiration, and try to do suction with the NS, and try to catch up the important where the bleeding is, important point where the pathology is. Try to catch off that. When you catch that, you will be safe, and we can you can think, you can plan it that time. Where is it? And it is tubal abortion or ruptured ectopic pregnancy, or somewhere in the ovarian pregnancy. All these things, interstitial pregnancy, or other things like somewhere outside, and it going to come out like that. All these things you can see, or else, and it is still present there itself. The pregnancy is pregnancy sac will be there in the tube, and also bleeding, trickle, small amount of the bleeding will come into the cavity, like that. All these things we should look. Coming to this ovarian pregnancy, of course, this is the second most common outside the uterine, outside the tube. And here the Spiegelberg sign, what they say, and the sac should be in the ovary itself, and it should be covered by the ovarian tissue, and also round, it should support the round ligament, and nothing, and uterus should be intact, like this. These are the criteria for the ovarian pregnancy. When you see the ovarian pregnancy, you nowadays we have good cauteries, and you can take out that sac and do cauterization, and and observe for 2 3 minutes whether it is still bleeding or not. And in some cases, when there is still bleeding is there, that time only you can remove the you can do ovariectomy. And coming to the ligament pregnancy, that is, if it is broad ligament pregnancy, then we should be very careful, because once it goes into the broad ligament, and we don't know how much bleeding is coming from that site, and where the trophoblast is implanting, on which vessel it is implanting, that is most important. So in anyway, we have to clear, and we have to enter into the broad ligament, or else we have, if you suspect more bleeding is there, uterine artery ligation, and this ovarian artery ligation, and even round ligament should be ligated to control the bleeding. Coming to the this abdominal pregnancy, of course, there are primary and secondary abdominal pregnancy. The instance is very rare, and primary is the rarest, but secondary abdominal pregnancy can be little bit more common than the primary. And in this, you can see, if it is attaching the uh, I mean, broad vessel, better to leave the tissue, and whatever the sac we can extract and remove that sac, and don't try to go into the root, and take don't get into the problems like that, because we can leave some amount of mm, uh, placenta, and you can just watch, still it is bleeding, or do cauterization if it is not important vital if it is not vital organ. You can, like on mesentery, and on, if it is there on the mesentery, you can remove little part of the mesentery also by laparoscopy. So So, coming to the interstitial pregnancy, it is almost 30%, and most of the times the ectopic pregnancy will occur only, most of the times, in ampullary region only. But if it is in the interstitial part or corneal pregnancy, the bleeding will be more, pain will be more, and management. If it is corneal pregnancy, while doing laparoscopy, it is very difficult to control the bleeding, because at the corneal end, we have to go on cautery, do cauterization, till, and otherwise what will happen, it will get opened up, and bleeding will be more. So in some cases, very rarely, but I don't want to tell it is the treatment of choice. In very rare cases, we have to do an uterine artery ligation and other things, and sometimes patient may even patient may we have to do hysterectomy for the patient if it doesn't control interstitial, and also in the corneal pregnancy, if she is having already children, like that. We thought of giving anti-D injection all the time, and tubal surgery, for most of the times we do tubal surgery for the tubal ligation, and when we are keeping the these tubes, that rings for the tubal uh, tubectomy. There most of the times we will see the length of the tube, and based on that we put that clips, like rings we put, floppy rings we put, and then what will happen, once we put floppy ring, and the other side small opening, after some time it will get open from the other side, and ectopic pregnancy can occur in the femoral end also. So that is also most important. For like in few cases, if it is unruptured and everything is good, we can do salpingostomy and remove the sac, and also suture with 70 catgut, or proline like that. Most of the times we have to give we use proline only, and linear incision, small linear in the antimesenteric border, and extract it, and we can close it. But in this also, slowly we have to do, and we have to control the hemorrhage. Control the hemorrhage. If you think it, we are not able to control, better to remove the tube itself. That is more safer than doing this, taking more time in that compromised septic shock patient. I mean, hemodynamic shock patient. Salping, we can just close it with the 70 Vicryl or Proline. So salpingectomy also, it is advisable for some, as I told you just now. And if we cannot control, better to do salpingectomy also. And segmental resection and anastomosis, in those patients, what we should do, always send it for biopsy, suspect some tuberculosis in such kind of patients. So medical management of the ectopic pregnancy nowadays, most we all are doing, because this is surgically administered medical treatment. It is called surgically administered medical treatment. That is, methotrexate is the drug of choice, and is a folic acid antagonist, and it has high affinity. And it will act on the trophoblastic cells. It will try to kill the trophoblastic on the against rapidly proliferating trophoblastic cells. So, when what are the indications? The indications are, we should think very clearly. And if the sac is less than 3.5 centimeters or less than 4 centimeters, and when there is no fetal heart is there in the sac, and that means less than 6 weeks, and serum beta, when serum beta is less than 10 to 15 uh, international units per ml. And this is the criteria to give this methotrexate injection through transvaginal or transabdominal into the sac. So, and one more thing, important thing is, whether the patient can come for the checkup or not. That is also most important. Once she takes that methotrexate injection, and she should not disappear. We have to follow her up properly. If she can come, then only start giving methotrexate injection, because there is no guarantee that the ectopic pregnancy sac will completely disappear by giving this injection. So every 2 days we have to do serum beta HCG and see other signs and symptoms of this ectopic pregnancy, and whether the sac size is decreasing. Serum beta HCG is coming down, and it should come down by at least 30% every alternate days. These things are very, very important in management with the methotrexate. When you give methotrexate, always do liver function test and also renal function test, and CBP is very important, platelet count, other things we should see, because it's an folic acid antagonist. So coming to the cervical pregnancy, it is very rare, but it can occur. And a patient is having a previous Asherman syndrome, previous cesarean sections, and also fibroids, and in IVF patients also. After doing embryo transfer, it may come down and implant in the cervix itself. In these patients, the criteria is also important. Survey, when we do pelvic examination, uterus size is normal, internal loss, and most of the times it is very difficult to diagnosis. And when patient is having bleeding and pain, most of the times naturally we think of the incomplete abortion or threatened abortion or inevitable abortion, all these things. But gravitic test become very positive. Cervical os may open in some cases. So, and so for like all other pregnancies, when we diagnose with the transvaginal scan, better like all other pregnancies, take IV access and do emergency management and blood cross matching and blood grouping typing. Everything should be done. And the advantage nowadays for the ectopic pregnancy, we can do hysteroscopy. we can diagnose hysteroscopy and do cauterization with the bipolar most of the times. And in non-surgical management is only with the methotrexate administration. Coming to the ovarian pregnancy, we thought of now the problem with the ovarian pregnancy is the most of the times we think about that in differential diagnosis. So follicular, I mean. A cyst, a follicular cyst, we have to differentiate between the follicular cyst and the ovarian pregnancy. But even in just now we have discussed about Spiegelberg criteria for the diagnosis of the ovarian pregnancy. So, sorry, and heteropic pregnancy, because the heteropic pregnancy, the pregnancy, the sac will implant in the uterine cavity and as well as in the tube. This is the heteropic pregnancy. Most of the times it will occur in the IVF patients itself. When we do IVF, and sometimes one embryo will go into the uterine cavity and other will travel into the tube, fallopian tube. There we find like a heteropic pregnancy, but most of the times in scan we will come to know. And also in not only in IVF procedures and also in ovulation induction, good ovulation induction also it can happen. And coming to the differential diagnosis of the ectopic pregnancy, which is very, very most commonly, we see that it is 100% uh, we should know what are the things we have to exclude. Like splenic rupture, if patient is having splenic rupture, she will also present with the same complaints, like she will become cold and clammy, hemorrhagic shock can occur, and pulse rate will get increased and BP will come down. And the thing is, and entire abdominal wall become like rigid, and same like shoulder pain will be there, and blood will be there under the diaphragm. Because of that we have to exclude splenic rupture, and it happens in accidents and other things uh, that we have to exclude. And also gastric and gastric ulcers, perforated gastric ulcer and perforated peptic ulcer also we have to think. And in those cases also the rigidity will be more, but whereas in ectopic pregnancy there won't be much rigidity. Tenderness will be there in the I mean below the umbilicus. And but in these cases they have lot of rigidity. The abdomen will become like bored, and rigidity, tenderness will be there all over the abdomen, from above umbilicus to uh, below, like that. This is also more important. Next thing, the commonest thing is the appendicitis. When patient present with the appendicitis, most of the times we think this right iliac and the point pain. We always see that whether she is having tenderness in the right iliac fossa. All these things we think, but always do better to do in, I mean, active reproductive women, better to do this urine for pregnancy test, and if it is possible, put her under observation, and we can look like exclude appendicitis, try to exclude appendicitis, but in appendicitis, temperature will be there, and also C-reactive protein and leukocytosis will be there. That is the most important thing. This WBC will increase, unlike in other conditions. Not only this, and also severe salpingitis and pelvic abscess. Also, they present with a severe pain abdomen, and leukocytosis will be there, temperature will be there, pain, tenderness, of course, amenorrhea may or may not be there. Pain will be there, and amenorrhea may or may not be there in those cases. So, or, and one more thing, always think about the twisted ovarian cyst. And we always get like if patient is having small follicular cyst also, they will have twisted ovarian cyst. And big follicular cyst, they may have twisted. In unmarried people also, we get that twisted ovarian cyst. If patient is having suffering with the, with the ovarian mass, and it may twist once or twice. If it doesn't twist also, and bleeding will be there, and also severe pain and temperature. Same, it will mimic like the ectopic pregnancy. In those cases, we have to rule out by doing scan and eliciting history. If she is having gram index positive, always think about the ectopic pregnancy. Or if it is not positive also, please think about the ectopic pregnancy and try to rule out by doing proper clinical examination, eliciting the proper history. So these are the things in ectopic pregnancy. So if you have any doubts, please you can call me. Thank you. Thank you for your patience listening.
Thank you, ma'am. Thank you so much for the beautiful presentation.
Thank you. Yeah.
So, ma'am, we will move on to the questions now.
Yes.
Let me see what are the questions that have come. So, first question is, a patient diagnosed with an ectopic pregnancy is hemodynamically unstable. What is the most appropriate initial management?
Yeah, and then we have to immediately, if blood is not ready, we have to give like hemoxil and other things. And also we have to immediately give blood transfusion and put her, do, if patient is in shock and cardiac arrest, something like that, do CPR, put oxygenation and head low position, and all these things we should do. Immediately put catheterization and start a normal saline and try to start a hemoxil. And whenever these things are there, and better to call anesthetist as soon as possible, or into the critical care, I mean critical care ward, we have to put her, immediately shift her to the operation theater. But in ectopic pregnancy, if you diagnose, the mortality is very less. When you start treat the patient, everything will become normal, and slowly she will come out of that problem. So always take her into the operation theater and do such things, and give 100% oxygenation, hydrocortisone injection if necessary, even adrenaline injection also we have to give. Patient undergoes cardiac arrest. CPR you should not forget, and all the doctors, they should know CPR properly, and try to, if anything happens in front of our eyes, we can save the patient. If it is not in front of our house, we may not save. But when we are there, and at least one or two people are there in with the patient, we can save the patient somehow. And even in some cases, if patient is having more bleeding while you are doing surgery, if you see more bleeding inside the pelvic cavity and the abdominal cavity, when there is no blood available, even you can give auto transfusion. In such cases, auto transfusion is, we used to give many auto transfusions in government hospital. When we open the abdomen, in those days, we have to take that blood from the abdomen, and we have to filter with the gauze, and we have to directly give to the patient. That is because that we need not, when you give auto transfusion, we need not go for the cross matching, we need not do blood grouping, that time saving will be there. So immediately we can give the blood transfusion to the patient, and always try to keep everything to resuscitate the patient.
Right, ma'am. Thank you so
when
much for
patient
giving.
when patient becomes little bit stable, but don't hesitate, shift her into the operation theater and find out the bleeding point, and take it and cut it and ligate it. And if everything is not ready, even laparoscopy is not ready, but don't hesitate to give incision and do laparotomy.
Right, ma'am. Thank you so much. Ma'am, there is a case, a 28 years old woman presents with amenorrhea, lower abdominal pain, and a positive pregnancy test. Transvaginal ultrasound does not reveal an intrauterine pregnancy. Her semen HCG level is 1500 MIU/ml. What should be the next step in management?
Yeah, in the if patient is stable and keep her under observation, because most of the times all pregnancies may not become ectopic pregnancies, and it will and while traveling the tube itself, the trophoblast may come out, because 1500 is very less. But better to keep her under observation and see after 2 days. Repeat her serum beta HCG alternate days. And if it is rising, and you search for the sac, where the sac is, like that. And if it is coming down, then you should think like that. It was traveling in the tube, and it just came back, and it fell in the I mean abdominal cavity. So all this trophoblast will not become ectopic pregnancies, or not implant in the uterine itself. Most of these trophoblast fertilized eggs, no, these embryos will fall down, and unknowingly the abortion can occur, or it may go back into the cavity. I mean, in the pouch of the Douglas. So maybe she's having early pregnancy loss, and whether she had just observe whether she will get her periods in 1 or 2 days, or whether we have to wait uh, till the sac becomes possible. But one thing you should tell the patient, we are suspecting that you may have ectopic pregnancy. For that, we are observing you. But whenever you feel like pain abdomen or bleeding or any, all these things, please report to the hospital. That should be. And alternate days, we should call the patient for the serum beta HCG.
Right, ma'am. So you are suggesting that in such cases, patient education plays an important role. So
Yes.
patient should be well aware of the
Yeah,
situation.
we should educate the patient regarding this problem, and we should tell her husband, and no intercourse is advisable in those cases. And also, lifting of the weight, lifting of the babies, those things should not be. These things are they should avoid. Just only observe, and if she gets her periods normally, no pain, nothing, so that is relieved. That means she was having early pregnancy loss. That's it.
Right, ma'am. Right. Thank you so much. Next question is, what are the contraindications for methotrexate therapy in ectopic pregnancy?
Yeah. And if we already thought of the indications for the methotrexate injection and all these things. And if it is more than 4 centimeters sac, that is one thing. And also when there is fetal heart is there in that sac, that is also in the sac. And also if patient is suffering with the any renal problem, or any like jaundice, any liver problem, in those cases also. And most of the thing, the number one is, if patient cannot come to the follow, that is the most important thing. In those cases, if patient is in some village, or she's going out of station, she wants to take only one injection and go. That is not advisable. For those patients, better to do laparoscopy or laparotomy. But when patient wants to come again for the follow-up, and also in all these criteria, you should do. If the serum beta HCG is more than 15,000, better not to give this injection, methotrexate injection. We can give methotrexate injection intramuscularly and also transvaginally into the sac.
Right, ma'am.
Yeah,
The
and
last
also
question.
see her platelet count, hemoglobin content, liver function, and if patient is having any other things, better not to give this methotrexate, because it is a antifolate and antagonist. Better not to give.
Right, ma'am.
BTCT, yeah, yeah, yeah,
Ma'am,
BTCT, uh,
please
all these
continue.
things we have to see. Yeah.
Okay, okay, ma'am.
Coagulation profile always you should see when you give the methotrexate injection. Okay, because it will act even on the platelet. So these things we should see.
Okay, ma'am. Last question for today. What is the most significant complication of a ruptured ectopic pregnancy, and how should it be managed emergently?
Yeah. Can you repeat it again, Arpita?
Ma'am, what is the most significant complication of a ruptured ectopic pregnancy and how it should be managed?
Yeah, when significant complication is only hemorrhagic shock, and we have to think about the mortality of the patient. So the problem for the patient. The significant complication immediately when we recognize the ruptured ectopic pregnancy, we have to do laparoscopy or laparotomy based on your experience and your facilities available in your hospital. Those things. The once ectopic pregnancy ruptures into the your uterine cavity, and control of the bleeding is more important. We have to identify the vessel or this place where the bleeding is there, and those things we have to catch it up and ligate and cauterize it. And once the patient is having ruptured ectopic pregnancy, the chances, if you when you clean also, you do suction and irrigation also, the complication of, like, in future complications, what will happen, addition formation may be there. And second time also, in almost 15% of cases, second time also she may have ectopic pregnancy. We don't know, in this tube she had ectopic pregnancy, it got ruptured. Maybe in other tube she is having hematoma, I mean blood in the other blood in the other tube. Hematosalping is also may be there in the other tube. That may also become organized in future. Again, epithelium will get damaged, and cilia may get also damaged, and in future she may have ectopic pregnancy. These are the later complications, but present complication and hemodynamically she we have to see later also, and we have to even check for hemoglobin next day or after 2 days, like that we have to check for hemoglobin. And once our tube got spoiled, one tube got spoiled, we remove that tube. And what about the second tube? We have to look into if she is if she is not having children and she is undergoing some treatment for infertility and other things, keen to conceive, you look into the other tube whether it is, if it is infected and peritubal additions or other additions are there, and better to ligate that tube also, because at the cornel end of the tube you have to close the thing. Otherwise, if it got ruptured and you removed only that part, you left a little bit of the tube, and in that tube also, in future she may have ectopic pregnancy. That is the reason, whenever you suspect a severe pelvic inflammatory disease and patient had ruptured ectopic pregnancy, think about the other tube, whether we have to remove, whether we can remove the tube, in because later in future she should not have complications like infertility complications, and again recurrence of the ectopic pregnancy complication. That is the reason. And contralateral tube and ipsilateral tube, both tubes you may have to ligate and in future and do her IVF, because only uterus is there. And I have seen one patient with three ectopic pregnancy. Two tubes were removed, and third time she had cornel pregnancy, and three over no, and fourth time she had to go for IVF, like that. So consequent, I don't know what was the problem. Continuously she had ectopic pregnancy with IVF itself, like.
Right, ma'am. Thank you, ma'am. Thank you so much for sharing your experiences, such risky conditions that you have. If you think of, you are being scared, like thinking of such situations. But thank you so much, ma'am, for sharing your experiences with us.
Thank you. Thank
And
you.
since there are no more queries from the audiences, so I would like to conclude the session for today. And thanks to you, first of all, for sharing your valuable information with us and sharing your valuable time with us. And of course, thanks to all the audiences for joining in, for putting their questions and making the session a successful one. So thank
Thank
you
you
all.
all. Thank you all.
Thank
Nice
you.
to see
Thank you
you.
so much,
Thank
ma'am.
you. Thank you for your
Thank
help.
you, ma'am.
Thank you. Bye
Thank you,
bye.
ma'am. Take care. Yeah. Bye.